Hi, my name is Lauren Doy. I'm one of the junior doctors in obstetrics and gynecology. I'm an ST2, and today I'll be giving the talk on reproductive medicine. This is normally a workstation within the theme day 3. So I like to start this talk with looking at a bit of epidemiology. So having a think percentage-wise, how many couples will experience subfertility, and the number of couples who are never able to conceive. Quite often the standard is that in primary care we only do baseline investigations and referral to fertility services if the couple have had a year of regular intercourse without being able to conceive. So we'll have a think about the conception rate after 1 year and after 6 months of regular intercourse. And age plays such a big factor in female infertility. We'll look at the chance of conceiving after 40 years of age. And then lastly, have a think if you know the peak chance of conception, so when in your menstrual cycle is the best time to have sex to try achieve a pregnancy. So if we just go through the answers for that, the number of couples who experience subfertility is about 15%, so 1 in 8 is most often quoted, which is a large proportion of people, and it's obviously a sensitive and emotive subject. Quite often people of similar ages amongst your friendship group, everyone will be getting pregnant, and it can be very upsetting if you reach the time of your life that you wish to get pregnant and it's taking months and months in order to achieve that. The number of couples who are never able to conceive is about 4%, so relatively low, but still something to be done and more research to be done to help those. The conception rate after 1 year of regular intercourse is 85% and only 60% after 6 months. So you can see why the recommendation is that we don't investigate until at least a year, because you have a much better chance of conceiving if you give it more time, and even better if you give it 2 years. However, the chance of conceiving after 40 is only 50%, so you wouldn't be asking a 40-year-old woman to wait a year before doing some baseline investigations and referral. And your peak chance of conception is actually 2 days before you ovulate, because sperm can survive 3 to 5 days. The egg is less, it's 24 to 48 hours. So couples who use these ovulation sticks or various apps that you can track your cycle, most of the evidence suggests that these do not help, because quite often they will suggest for you to have sex too late, and all the evidence, all the recommendations is for couples not to use these, as it just makes a stressful situation even more stressful. So, in order to work out what history we take for presentation of subfertility, what baseline investigations we do before referring on, I always like to get the students to sit in groups and come up with all the different things you need to make a baby, and then that can give you some clues as to the questions you need to ask and the recommendations you need to make. So if we just go through this slide here, the first thing you need is a healthy man. So by healthy I mean normal BMI, which is shown to help. Non-smoker, so smokers are not eligible for IVF, and they do carbon monoxide readings, so couples have to stop smoking, and it also has a big impact on fertility. The other things to think with men is that the testicles are naturally meant to be at a slightly lower temperature than the rest of the body, so things like working with a hot laptop on your lap, wearing tight underwear, riding a motorbike, all of these things affect male fertility. And regular exercise and a healthy diet help. The next thing you need is a healthy female. She has to be the right age, as we've seen on the previous slide. Again, normal BMI, not too big and not too small. Being underweight leads to anovulatory cycles, and your chance of conceiving is much better if your BMI is over 18, nearer sort of 22, 23. Again, a non-smoker, and it's always worth suggesting to women who are trying to get pregnant that they take their folic acid supplements. The evidence is that you need to take this for at least 3 months before you get pregnant to have adequate protection against neural tube defects. Then once you've got a man and a woman, they need to be having frequent sex. So the evidence is that sexual intercourse once or twice a week, every week, is much better than just having sex around the time you think you ovulate. So this is what's meant to be recommended. Some research has shown that the immune status of the endometrium can be pro or against implantation of a fertilized egg, and there's some evidence to show that frequent sex ensures that the endometrium is ready for implantation, whereas infrequent sex you can have immune modulating rejection of the fertilized egg. You need to have penetrative sex, and you need to have semen. So psychologically you can be asking the couples, are the men not able to ejaculate for a psychological reason, etc. You need patent fallopian tubes. So the big cause of problems these days is a history of chlamydia infection, which can cause tortuous blocked fallopian tubes. This can also have impact on the success of IVF, as sludge or mucus backflows into the uterus and can prevent implantation. You need ovulation, so obviously the woman has to be ovulating. There are lots of conditions, hypothyroidism, hyperthyroidism, polycystic ovarian syndrome, low BMI, as we said earlier, that can cause you not to ovulate. And you need a healthy egg. And when we talk about healthy egg and healthy sperm, we're talking about good DNA, no DNA damage. That's what smoking and high BMI causes DNA damage in these. And the healthy eggs, women are born with about 500,000 eggs, and then ovulate them. So the older you are, the older your eggs are, where sperm is produced every couple of months. And then you need a thick endometrium, which allows for implantation. And once all of those things come together, then you have a pregnancy. Of course, there are probably a lot more factors that come into play, some of which there's some basic research on, some of which we don't understand. And so when you're thinking about unexplained fertility, there's probably extra things in here that we not quite understanding, and so therefore it's difficult to diagnose. We don't have a way of looking at DNA within eggs and sperm to see if it's healthy or not. Definitely not offered on the NHS. There are some more fancy private tests that can help suggest, but there's probably quite a few things that we don't know about fertilization. So, if we then relate what we've just talked about, we can think about the epidemiology of subfertility. So, male factor infertility, about 25 to 40%. Tubal damage is up to 1/3. Ovulation disorders, 1/3. Unexplained subfertility. And endometriosis, just pointed out there that it's a big factor. It obviously can cause tubal damage, can cause ovulation disorders with chocolate cysts, and other 4%. So you'll have women who are found to have certain genetic variations. They may have underdeveloped reproductive organs, etc., etc. So let's go through some of the investigations that we do for the couple and explain what they're looking for. So male factor infertility, so this is an easy one. You just get a semen sample, look at it under the microscope, the volume, the pH, how many sperm there are. Are they motile, so are they moving? Are they moving forward, progressive motility? Are they alive? And what do they look like? Do they have one tail? Are there any with two tails, etc., etc.? And men are told to have a couple of days of abstinence, and then if any abnormality is found, you can give general lifestyle advice and then repeat, and often you can see improvements on that sperm analysis. If it's grossly deficient, then you repeat it straight away. And that's all that we really test the man for, apart from sexually transmitted infections, which don't so much have much to play in male factor infertility, but will be affecting the female's chance of conceiving. So the next is looking at tubal factors. So if after your history you don't expect a problem with the tube, so there's no history of STIs, they're not painful periods, so you're not worrying about endometriosis, then you can do a hysterosalpingogram, which is the less invasive. So it's an X-ray with some dye, and you can see if it's going through the tubes and out the fimbrial end, or if they're completely blocked. However, if you are expecting to see problems, then actually the best thing to do is laparoscopy with a dye test. So if you can avoid this, because it's obviously an operation and there are risks with laparoscopy, but if you're suspecting other pathology, then this is what you do first. So you go in with a camera in the belly button, another camera through a second port, and then someone sits at the bottom end and injects blue dye up into the uterus, and if the tubes are patent, you'll see the blue dye dripping into the pelvic cavity. You can also have a look at the tubes. Do they look healthy? Do they look red and inflamed? You can have a look at the ovaries for any ovarian pathology. You can have a look around and see if there's any endometriosis, etc. So this is just a summary slide about the things that can cause problems with your tube. So STIs, chlamydia being the most common, severe endometriosis, history of pelvic inflammatory disease, etc., etc. Then if we look at ovulatory disorders, this is just your menstrual cycle with all the changes in the hormones and the endometrium. So you can see your luteal phase. The second phase is when you have your peak of progesterone and you build up your endometrium ready for implantation. So if this luteal phase is often shorter, you may not have sufficient endometrium for implantation. Generally that is less likely. There's often a change in the follicular phase and you don't get the hormones required to mature and release an egg, so you have an ovulatory cycle. And this is most commonly seen in polycystic ovarian syndrome, where you have very irregular periods. As a rule of thumb, if a woman is having a regular menstrual cycle each month, then more likely than not they are ovulating. Whereas if they have shorter or longer or irregular cycles, they need further investigation. But we can do a mid-luteal phase progesterone, and that can show you a way of proving ovulation. And you do it 7 days before the first day of the period. So in a 28-day cycle, that would be day 21. If it was a 30-day cycle, it would be day 23. If it was a shorter cycle, it would be slightly earlier. And that can be your first test in women to try and prove ovulation. So I talked about polycystic ovarian syndrome. So if you were to do an ultrasound, you may see the ovary containing all these cysts. Just to note that polycystic ovaries don't always go hand in hand with polycystic ovarian syndrome. Someone can have polycystic ovaries on an ultrasound but not have polycystic ovarian syndrome. So women can get very panicked if they have polycystic ovaries on ultrasound, but it's worth reassuring them if they don't have any other features of polycystic ovarian syndrome, such as high BMI, male pattern hair growth. And the test for polycystic ovarian syndrome also involves looking at sex hormone binding globulin and levels of testosterone before you make a diagnosis. Polycystic ovaries can be a good thing because all these little cysts are potential eggs to be released. Pelvic ultrasound can show you some other uterine abnormalities. So this ultrasound is showing a lovely uterus here with endometrium, nice thick endometrium, mid-cycle endometrium. You can have fibroids or polyps. So here you've got a polyp within the cavity, the uterine cavity, and this MRI just shows you a bit better. It's just filling the cavity, and obviously this woman would not be able to get pregnant. However, ultrasound's not the best way to view these things. The gold standard is to do hysteroscopy, so that's when we go with a camera. Often in the outpatient setting, woman doesn't need any sedation or any anesthetic. It's just a very, very thin camera that goes through the cervix and to look inside the uterine cavity. Occasionally, if this is too painful for women or the cervical cavity is stenosed, as in blocked, then we do it under an anesthetic, but more and more it's done in the outpatient department. So here's a lovely picture of a very healthy endometrium, and that's the ostia, so the opening to the tube. And this is the gold standard for looking at uterine changes, so you'll be able to just go in and see any polyps or fibroids, and you can treat at the same time. So if it's a small polyp, you can remove it. Same with a fibroid. The effect of polyps and fibroids on fertility is a bit controversial. There's some thought that if the fibroid is submucosal, it distorts the cavity, causes local inflammation and prevents implantation. But you often see women pregnant with fibroids. If it is thought that they're interfering, then they are removed. In an operation called a myomectomy, there's a risk of heavy bleeding with this operation, and if they cut into or breach the cavity of the uterus, then the woman has to have a cesarean section for her pregnancy. If someone has had a surgical evacuation of the uterus for a miscarriage or a surgical abortion, that can cause some intrauterine adhesions, something that's known as Asherman syndrome. It's very rare, but those adhesions can also prevent fertility, implantation. And you get these septa in the uterus. So obviously, embryologically, the uterus is formed from two different sides that come together, and the septum disappears in the middle, but occasionally you can get varying lengths of septum still there. We're unsure of their significance, but it has been shown to have increased risk of miscarriage, and sometimes they are removed to improve fertility. So I've just gone through some of the basics. By no means is it covering everything. I think it's important at your stage to be able to understand the questions you need to go through with a couple presenting with subfertility, the basic lifestyle recommendations you can tell them, and be able to tell them what baseline investigations you're going to send them for before referring them to secondary care. I've just put on here some references that are quite useful in coming up with that. I hope you've enjoyed this talk today, and I hope everyone is well during this quarantine, and look forward to meeting you on the wards in the future.